Hello, my name is Danny Reedy, and I am an RN MSN student at the University of West Georgia. For the past 3 years, I managed 28 home peritoneal dialysis patients in the West Georgia area. During this time, when my patients were admitted to a hospital for various reasons or had home health RNs coming to their home, most RNs were aware of special low phosphorus, special diabetic, and special renal diets. However, I would note the nurses seemed unfamiliar with the increased protein diet needs of my PD patients, especially after a health incident. Today, I'm going to be discussing the importance of increased protein intake in peritoneal dialysis patients. Objectives. At the end of this presentation, the nurse should be able to define peritoneal dialysis and explain an exchange. Define normal and abnormal serum albumin levels in PD patients. Describe hypoalbuminemia, side effects, signs, and symptoms. Discuss the RN role in preventing hypoalbuminemia in PD patients. Educate PD patients about albumin levels and need to increase protein intake. Urea is a waste product produced with the breakdown of protein. Unfortunately, in chronic kidney disease, the kidneys do not properly remove waste product from the blood. I have found that most RNs know that chronic kidney disease patients require low protein diets in order to prevent high levels of urea in the blood. They know proteinuria is a major complication and risk for cardiovascular health and residual kidney function in CKD patients. However, the moment the patient begins peritoneal dialysis, the blood is adequately cleaned. Due to the nature of peritoneal dialysis, which we will discuss more, an increase in protein intake is imperative. The RN must re-educate and stress the importance of this diet change. What is peritoneal dialysis and how does it work? Peritoneal dialysis is a type of dialysis for patients in ESRD or end-stage renal disease. It utilizes the peritoneal membrane cavity, which is the abdominal cavity that holds most of your abdominal organs. This membrane acts as a dialyzer or pseudo-kidney. A lot of times I would introduce this type of dialysis to my patients as a more natural dialysis. It's like a kidney you never knew you had. The peritoneal membrane is very vascular and works by filtering waste product and removing excess fluid through the process of diffusion, osmosis, and ultrafiltration. It works through an exchange. An exchange is a process of filling, dwelling, and draining. The patient will complete at least 5 exchanges a day. The first step is actually to drain. The patient will drain whatever's in the cavity before filling, making sure to monitor the current fluid for color, clarity, amount, and infection. The dialysate, as well as waste product and fluid, exit the body through the PD catheter into the drain bag or toilet. Filling. Based on patient weight and edema, a dialysate solution is chosen. All dialysate removes waste the same, but not all ultrafiltrate the same or remove excess fluid the same. Dialysate fills peritoneal cavity through the peritoneal catheter in the abdomen. Once filled, the patient can disconnect and go about their day. This is called the dwell. Dialysate dwells in the peritoneal cavity anywhere from 2 to 5 hours based on their personal prescription. During this stage, waste product and fluid are filtered out of the blood and into the peritoneal cavity. One of the known risks versus benefits of peritoneal dialysis is the protein loss per exchange. One of the first studies completed in the 1980s found that the amount of protein that may be lost during an exchange or the entire day of exchanges, is anywhere from 5 to 15 grams of protein a day. This is still the gold standard for peritoneal dialysis protein loss estimation. That's explaining why peritoneal dialysis patients lose protein. They do it just by doing their dialysis. This loss must be made up through diet. I'm a visual learner, so I wanted to provide 2 pictures of peritoneal dialysis. This is a CAPD exchange. The little patient is doing on the right-hand side. Both of these pictures are provided to you by Fresenius Medical Care. Fresenius Kidney Care is our new name. At the top of the patient, right at the top on the pole, you'll see the bag that is filling the patient. On the floor, you'll see the drain bag. And on the left picture, you will see the peritoneal cavity, and the dialysis solution is filling that cavity. Let's discuss serum albumin and the role it plays in peritoneal dialysis patients' nutrition. It's the most abundant plasma protein, making up 55 to 65% of the total protein found in blood. Serum albumin is an indicator of the overall nutritional status of the body, and it's essential for tissue regeneration and fluid balance. An albumin level of 4.0 and above is preferred in dialysis patients, especially PD patients. Hypoalbuminemia, as stated by Fresenius Kidney Care, is anything less than 3.7. Under 3.0, your patient's risk of death increases dramatically. Peritoneal dialysis patients whose serum albumin is less than 3.0 are at 3 times the risk of cardiovascular death and infection-related mortality. When your patient's albumin levels are low, you may notice an increase in swelling and edema in the body, especially around the eyes, hands, feet, legs, and even belly. This can be tough, though, to distinguish between low albumin levels and just excess fluid in ESRD. It's important to monitor your patient's weight and ultrafiltration levels daily. Lab values may also be skewed by excess fluid, so be sure your patient has efficiently dialyzed. In a patient that I cared for, as an example, his hands and feet were severely edemous, and this was regardless of what fluid and how much dialysis he did. As soon as we got his lab values back, we realized his albumin was less than 3.0. Unfortunately, this patient's albumin did not increase, and his nutrition level was severe. He passed away within 2 months of beginning my program. Your patient may also display signs of fatigue, jaundice, and be an increased risk of infections and poor wound healing when they have low albumin. Although weight loss is associated with malnourishment, your PD patient may or may not have weight loss. Do not use BMI as an indicator of nutrition. The facts. Malnourishment is an extremely common problem in peritoneal dialysis, occurring in 30 to 50% of patients. Malnutrition is measured by serum albumin levels. These levels are a crucial predictor of morbidity and mortality in PD patients. About 2/3 of PD patients experience hypoalbuminemia. In fact, one study from the US found that 63% of PD patients were in a state of malnutrition with low serum albumin levels. The causes of malnutrition in peritoneal dialysis can be various. Hassan stated that factors affecting the development of malnutrition among PD patients include low dialysis efficiency, peritoneal loss of amino acids and proteins through the peritoneal route, lack of appetite resulting from abdominal fullness, or related to the absorption of glucose from the dialysis solution and slow emptying of the stomach. In other words, malnutrition causes in PD vary. This can be from the type of membrane transport. If the patient has a high transport of fluids, they're at increased risk of protein loss. The dialysate dwell can cause abdominal fullness. It can cause a loss of appetite. This was a common complaint among my PD patients. Most prescriptions require 2 liters of dialysate to dwell in the patient at a time. Again, they have to do about 5 exchanges a day. Due to ultrafiltration and depending on the level of fluid needing to be removed from the body, the patient may have an extra 4 liters of fluid in their abdomen during an exchange. That's roughly 4 kilograms or 8.8 pounds. My patients would tell me all the time they just felt too full to eat. Other problems that may cause low albumin in PD patients are anemia, glucose absorption from the dialysate, various GI issues. In general, there's a list of comorbidities that can cause these problems for these patients. And as stated in the previous slides, a warning to nurses and healthcare professionals. Peritoneal dialysis patients often have normal or even elevated BMI, and at the same time, hypoalbuminemia with all its complications. The poor diagnostic performance of BMI may potentially explain the paradoxical association between higher BMI and lower mortality in this group of patients. Current research trends all agree. PD patients must increase protein intake. And this was found in these 3 articles. Supplementation is key in this population. 2 of these articles are research articles and 1 is a review of literature. All agree. Diet counseling is a must. Education for these patients is a must. In a lot of cases, supplementation was found to be a must. What can nurses do? It is imperative the patient be properly educated about the need to increase protein intake and maintain a 4.0 and above for their albumin level. Patient diet must consistently have adequate protein intake. The National Kidney Foundation Kidney Disease Outcomes Quality Initiative recommended daily protein intake for peritoneal dialysis patients be 1.3 grams per kilogram per day to maintain serum albumin levels at and above 4.0. The nurse must monitor dialysis adequacy and excess fluid removal. The nurse must monitor all lab values closely, especially anemia, signs and symptoms of infection, inflammation markers, and most importantly, they need to be monitoring those albumin levels to notice if their patient is in a state of malnutrition. All PD patients must have dietary counseling, especially patients who have low serum albumin levels, less than 3.7. Hospital RNs need to be aware of the protein needs of these PD patients. They must educate patients on the need to increase protein intake even more during infection, inflammation, surgery, and malignancy. All will cause albumin levels to drop. If a PD patient experiences any of these health problems in addition to their ESRD, a very high protein diet will be needed. The RN may need to suggest to the attending physician a protein supplement to be added in addition to the regular patient diet. One of my favorite duties as a home dialysis nurse was educating patients monthly about their individual albumin levels. I wanted them to understand the imperative need to meet albumin goal of 4.0. I witnessed firsthand patients whose albumin levels fell below 3.0, and every one of them passed away from various complications. It's important that the RN provides the patient with the education and tools to protect their overall nutritional health. I worked very closely with a renal dietitian to provide our patients with oral protein supplements. The picture up in the top right is of Liquicell. Liquicell became a favorite product. It's got 1 ounce of fluid, just 1 ounce of fluid, and that has 16 grams of protein in it. 1 ounce of that liquid is 16 grams of protein. They all have different flavors and are easy for these patients to take orally. I'm attaching the website below for you to share with patients. I would also make posters, handouts, and even have albumin parties for my patients with recipe printouts, prizes, taste tests of these Liquicell flavors. Compliance is key. Most PD patients know that albumin is necessary. They know what it is. They're aware they need to be increasing their protein intake to increase their albumin. But few feel confident to tell their hospital nurse they need an increased protein diet or protein supplement in addition to their meals. I truly hope this slide better prepares you for caring for PD patients, either in the hospital or in the home. Thank you so much for your time. References are on the final page, and be sure to check out the notes in the PowerPoint as well as the comments attached in each slide. Thank you so much.